So every body system has something special, like people's well, right? So cardiopulmonary, people are into plumbing and the physics and all that stuff. Orthos for like those people who are like construction workers who just like building things with their hands, following the blueprint, right? Put that together and the dead hands and nails, screwdriver. Endocrine is really sort of like the logical mathematics part of the body, meaning like, okay, well, which hormone is high? Well, if that one's high, this one's low, must be something's happening in between. It's just sort of trying to, it's the algebra of. We're not really getting into that. We're getting into when things go crazy. You don't need to diagnose most things that happen. You don't need to figure out the HPA act. You don't have to get into all that necessarily in the emergency room. You have to figure out, well, okay, what's this person dying of right now? Cool. So let's see if this is possibly an introduction into endocrine. And we're really going to deal with four to five things: hypo and hyperglycemia, DKA, which is diabetic ketoacidosis, HHNS, which is hyperglycemic hyperosmotic. Didn't know what it stands for right now because my brain's not fully there, but we'll see in a minute. I think it's just HHS. Thyroid storm. What is the thyroid goes crazy? Too much thyroid hormone, too little thyroid hormone. Adrenal insufficiency. Too much adrenal is not working well enough, or it's putting out too much. And altered mental status will sort of be overarching. Hypoglycemia. So hypoglycemia is, sure enough, it's just low blood sugar. Well, if they're diabetics, then maybe what happened was they took too much of their medication, right? Maybe they took too much insulin, maybe they took too much ureas. And we'll see that the way those medications work, it's not so easy to always reverse those medications. It tends to be your type 1 diabetics more often than your type 2 diabetics. What's the difference between type 1 and type 2 diabetes? Type 1 is where the pancreas does not produce enough insulin because sometimes it's an autoimmune thing. It's often a genetic thing that they're born with. Type 2 is more where the cells of the body go on strike. So many people knocking at the door with sugar to come into the cells that after a while, so it's like, no, we're not taking it. Thank you. We can keep it in the bloodstream. Right? It just stops responding to it. So type 1 diabetics tend to be the ones who have hypoglycemia more than type 2, and they're going to come in tired, maybe sweaty, diaphoretic. Diaphoretic is just dripping sweat, tachycardic, maybe some mood swings. And there may be some neurological symptoms, slurred speech, seizures, altered mental status, which is always, you have to wonder, like, is there a stroke happening here? Is there something else happening here other than blood sugar? However, luckily, we have a very quick bedside test we can do to see if it is blood sugar. What is it? Bedside glucose. Great. So if they have a bedside glucose of 15, okay, I think we figure out what's going on, right? The other thing we want to look for is something called Whipple's triad. Whipple's triad. What is Whipple's triad? Well, think about Whipple's triad as whipped cream, okay? And it's actually incredibly intuitive if you can. Somebody comes in with hypoglycemia symptoms, central nervous system symptoms. That's one step of it. Step 2 is they have low blood sugar. Hypoglycemia symptoms, low blood sugar. Everyone with us? Makes a lot of sense, right? And then, okay, give me a quick minute because things got twice by somebody. So this makes a lot of sense, right? So hypoglycemia symptoms. They have low blood sugar, and then sure enough, you give them sugar, they get all better. Makes a lot of sense, right? That's Whipple's triad. But interestingly enough, often it could be diagnostic of an insulinoma. Could be an insulinoma, which is so meaning there's something which is creating too much insulin. That's why the blood sugar pump. Now let's say you give them glucose and they don't get better. So let me take that back. Let me take that back. If you give them glucose and they don't get better, that could be a big difference. Why? Because you're giving them sugar, it's not getting better. So why? Well, because the body's creating too much insulin, it keeps fighting it. Okay. Is that clear for everyone? Great, because I interrupted, that's my fault. This is just one way of helping you diagnose hypoglycemia. Essentially, they come in with symptoms of hypoglycemia, then turns out they have low blood sugar. You give them sugar, they get that. That's basically Whipple's triad in a nutshell. All right. If you give them sugar and they don't get better, there might be something else going on. It's not simple hypoglycemia. That makes sense. Yeah.
So it's just saying that if that happened, it was hypoglycemia.
Yeah, basically. Okay. As opposed to some outside factor stopping that from happening. Right? Like if they're septic, it doesn't matter how much sugar you're going to give them. There's other issues. So what could cause hypoglycemia? Well, could be they're not eating. They might not be eating enough. They may even be an alcoholic. They could be living off of booze. That was the only thing they've eaten the past few days has been pint of tequila. Could be. So you can check their ketones and see if that's part of it. You have some ketosis. Starvation. Could be a critical illness, sepsis, liver failure. Go and check LFTs, you check lipase. Check their cortisol. Sometimes it can come about because their body's not making enough steroids, could be some adrenal insufficiency. Or it could be that they're using too much insulin or sulfonylurea. Have we had diabetes meds in farms yet? We'll circle back to this next slide, but real quick, I just want to draw your attention to specifically how one of these works, and that is sulfonylureas. Sulfonylureas that medicine means whenever, what it does is whenever glucose enters the body, it causes the pancreas to make more insulin. Whenever glucose enters the body, it causes the body to make more insulin. So, imagine someone took too many sulfonylureas, like glyphosate, and now they're hypoglycemic. Is giving them glucose going to be helpful? Think about what's causing. The medicine is causing the body to create too much insulin in response to glucose that comes in. So I'll give them more glucose. What's going to happen? Body's going to make more insulin. So in those cases, that's why it's important to get a history. In those cases, it's possible that glucose will not be helpful. Talk about what it does mean. How would that fix that? So it causes the pancreas to make more insulin whenever it gives more glucose. So now this person has really low blood sugar, and you give them more glucose. It's going to make more insulin to counteract the glucose. So what do you do with these patients? So first of all, ABCs. Then keep giving them finger sticks until their blood glucose gets back to where you want it to be. So if they can swallow, you don't need to play around with like dextrose or IV fluids. Just give them sugar. Just give them sugar. All they have to do is get some ice cream up there. Okay. If you can't give them anything PO, you can give them IM glucagon if you don't have an IV product available. Or if it's a sulfonylurea, we give octreotide. There's the octreotide more or less in only one other place, and that's going to be with esophageal upper GI foods. But it's sort of like a rock, paper, scissors situation. Sulfonylurea is killing the glucose, octreotide beats the sulfonylurea. Okay. If they have altered mental status already, you're going to have to give them D50. That's straight IV sugar. Basically, it's 25 grams of glucose already mixed into 50 milliliters per 50 milliliters of saline. Then you want to check their blood sugar every 30 minutes to make sure there's no rebound hypoglycemia. basically because all this extra sugar is going in, it's going to be taken in quicker, and therefore it's not going to be kept in the blood. Okay. The tricky thing with D50 is it's hyperosmotic, which means it's going to be constant. So you have to be careful with it. But again, the number one treatment for hypoglycemia is sugar. Okay, so let's say you give someone 6 liters of D5W, right, which will come out to about the same amount as a pint of Ben & Jerry's ice cream. So if they're able to swallow, which is going to be more effective, Ben & Jerry's ice cream, right? So just something to keep in mind. That's one end of the spectrum. Let's go to the other end of the spectrum, something we may be more familiar with. That is someone who has diabetic ketoacidosis. These are people whose blood sugar is so high, it's starting to create ketones in the body. They may have difficulty breathing. They may have some altered mental status. The reason they're breathing strongly is not because they're having airway issues. You don't need to intubate them. In fact, that might make your life harder. The reason they're trying to breathe harder is because they're trying to breathe off all the acidosis from the ketones in their blood. Okay. Sometimes DKA may be the first time these patients find out they're diabetic. Maybe the first time they find that out. Often it's going to be type 1 diabetes, younger patients, for whatever reason, female and non-white tends to be more prevalent when they show up with that person in DKA. They may have an insulin pump. It may be that they are university freshmen who have, for the first time, they're on their own and they're just not paying attention to the sugar, the way they should. Right? Drinking more, sleeping less, eat, ramen, you know. So how do you diagnose it? Well, your blood glucose is over 250, which could be where some people live. That itself is not DKA. But now their pH is under 7.3. So is that acidotic or alkaline? Acidotic. Okay, because all these ketones. Their bicarb is low, under 15. And in the blood, in the urine, you'll see ketones. They'll also have a very large anion. I'm not going to get into how to calculate an anion gap. Just review that and remind it, very large anion gap. DK is one. This is what I meant to say. Hyperglycemic hyperosmosis syndrome. This is a little different. So this is a pretty serious complication of type 2 diabetes. It's most commonly going to be in older people, people who are institutionalized. And what you'll notice with these patients is they tend to have altered mental status. There's some neurological symptoms that are occurring here. Because they're hyperglycemic and because they have higher osmolarity due to that. Well, I don't know, because this is an older person who has altered mental status. I want to get CBC and lactate because it could be caused by some sort of infection. Make sure that's stuff. And we're going to CMP, MAG, and PHOS. That CMP, as much as I sort of said, it's not really necessary with cardiac concerns or possibly, airway concerns. When talking about diabetes, CMP becomes pretty important even in the treatment of it. Make sure you get the CMP, make sure you get a MAG and PHOS. Check the osmolality of the serum and the urine. Get some cultures again to make sure it's no sepsis. Beta hydroxybutyrate. Essentially, those are ketones. Are there ketones in the blood, ketones in the urine? Chest X-ray, EKG, and other imaging is just going to be based on how they present. If you're worried about a stroke as well, then go get that CT. Okay. How do you differentiate HHS from DKA? Well, first of all, I have those neurosymptoms. But more importantly, you'll notice there's no ketones in the blood or the urine. That's what differentiates. There's no ketones. Now, they may have a higher bicarb. They may have no acidosis of the blood, because we're not talking about ketones. They just have super high glucose. super high. 600 over 600, serum osmolality is over 315. Essentially what it is just super thick, sludgy blood. Okay, because of all that sugar, but there's no ketones. No ketones. And it may not be caused by diabetes. Sometimes it can occur with stroke, MI, sepsis even. On the other end of the spectrum, someone can be hyperglycemic without neurological impairment, and that is not HHS. HHS is specifically hyperglycemia with neurological symptoms. So if this is just sludgy blood, we're just dealing with sludgy blood, excuse the grossness of the metaphor, then the number one thing is to get hydration. You've got to clean that out. You've got to really help dilute that hyperesmol. Let's talk about how to treat DKA. The number one thing you must do is volume repletion, IV fluids. Then whatever's been happening in the body because the insulin isn't there, because it's all that extra blood, right, blood sugar, is reverse whatever metabolic consequences that comes out. Then you can worry about correcting electrolytes. After we have them stable, figure out what caused it and make sure there's no complications. And go step by step. First thing you want to do is get volume. Get IV fluids. That's for whether you're dealing with DKA or HHS. Get fluid. The first 12 hours, you need to do over 50%, about 50% of their fluid deficit. So what does that look like? You give them 2 liters for the first 2 hours, 2 liters for the next 4 hours, from hours 2 to 6, and then 2 liters from hours 6 to 12. Usually that will do a good 50% of the deficit, and the remaining 12 can be over the next 12 hours. Excuse me, the remaining 6 liters can be over the next 12 hours. Then you can use normal saline or lactated. You want D5 in these fluids? Bad idea. Why? Sure. Just trying to keep it in context, right? Good. Okay, good. We got them on fluids. We got them. Yeah.
What's the deficit?
So they're often very dehydrated because they have ketones. Taking up a lot. They have ketones. They have high osmolality of the blood. So usually a pretty large fluid deficit.
We need to like calculate that deficit.
Usually that's what we do is 6 liters the first 12, 6 liters.
Oh,
yeah. There might be a liter per kilogram sort of situation out there.
Right. That's what.
Just worry about
Just worry about this.
Okay. Focus. I won't ask you to calculate. Okay. Yeah. So 2 liters for 0 to 2. So that's like a bowl, which is wide open, right? Then 2 liters for the next 4 hours, and 2 liters for the next 6 hours. And then the remaining 6 liters will be from hours 13 through 20. Get it back into your truck. Okay. Is everyone okay with the fluids? I don't mean you personally, it is very hot in here. But then potassium, pay very close attention. When you take their first finger stick, they may look like they're hyperkalemic. They may look like they're hyperkalemic. Why? Because they're acidotic. There's more potassium just naturally in the blood. But once, remember back when we did hyperkalemia in ClinMed, one of the ways you help with hyperkalemia is by giving them insulin to pump the potassium back into cells, right? What's going to happen once you start giving these patients insulin? It's just going to shove all that potassium back in the cells. All of a sudden, you find out they're extremely hypokemic. They're extremely hypokemic. Okay? So before you play around with insulin, find out what the potassium is. Now, the number one cause of hyperkalemia is lab error. Gets hemolyzed on the way to the lab. So they come back with 6.5, that's weird. Do another draw, right? But if you really are concerned they're really, truly hyperkalemic, get that EKG. Do the EKG to make sure there's no sign. So let's assume that we're getting a pretty accurate potassium reading. So what do we start with? So if the potassium is at least 3.3, we can go and start in. If it's under 3.3, we got to get the potassium up before we can get insulin. Got to get it up. So that's really the first one. Everyone go with that. Volume, potassium.
If potassium appears high, how do you tell?
So that's why we're getting those numbers, because 3.3 is a safe number. If it's reading at 3.5, 3.8 is that probably safe to get into the problem. But if it's reading 3.3 now, and even worse than it. But if you really think it's hyperkalemic, that way it's a if we were truly hyperkalemic, reading 6.5 and something to that. They didn't give you ratio from the party. So they get this.
I'm just.
That's true.
Usually, like, this 3.3 is the limit, but usually they're gonna be up.
No, usually they're not. Usually they're going to be a normal read. Well, you can assume it's an accurate read. Okay, you can assume that if you're getting 3.5, 3.6, it's safe to give them insulin. That it might drop once you give them insulin. You can assume it's safe to give them insulin if you're at 3.3. If it's at 2.9, don't give them insulin. It's going to be even lower. Get the potassium back up first. And then you might want to monitor to make sure that the potassium doesn't go super low while you're okay.
Yeah, I'm still confused by this.
Okay.
You might starting from the top, so.
Start from the top. Okay, great. So they're getting their fluids.
Okay.
They're getting their fluids. They're feeling a little better, right? Fantastic. If I jump, so often what's going to happen is the potassium level you're going to get from the CMP will not reflect the actual amount of potassium that will be in the blood. That, at homeostasis. Once you get the insulin moving, that potassium is going to shift into the cells. So we come up with an evidence-based red line. If the initial reading is over 3.3, it's safe to begin giving insulin without correcting the potassium first. It probably will dip, and you probably should keep an eye on it, but it's safe to begin the insulin now. We want to get the insulin going. This dude has sugar at like 550, right? We want to get the insulin going, but you can't do it until you get the potassium at least over 3.3. Oh, it's going to get dangerous.
But in reality, since usually they're going to be hyperkalemic.
It may look hyperkalemic. To be specific, it's going to look higher than it really is.
Right.
Okay, meaning whatever it looks like now, it's going to get even lower once you get this.
Right.
So in a normal patient, if they have 3.2, you might be a little worried, right? But you cannot begin giving them insulin until you get it over at least. Okay? Because it will get very low very quick. Yeah.
It's gonna be some percentage that. What is that?
Which one?
The potassium you can calculate that.
That means, in truth, the amount of potassium, which is going to be the amount of potassium you're measuring in the blood is really due to acidosis, not because of anything related to how much potassium really is in the blood at a homeostasis.
So you wanna understand that here.
There, you understand, once you give them insulin, their potassium is going to drop rapidly. That's all you need to do. So perhaps dangerous. Assume that whatever you're getting on this lab reading, once you start treating the ketoacidosis, they will become hypoglycemic, regardless of what the potassium says. Question is, how dangerous is it to give them insulin? Yeah. And it looks higher now than it was. It may even look like it's 4.2. It may look like it's 4.2, but once you get an insulin, it's going to drop down to 3. Yeah. But that's fine. 3 is safe. I can live with 3. I can't start with 3, give them insulin, and have it drop down to 1, that's gonna kill a patient. Okay? So how much safety net do I have before I start giving insulin? That's what we're looking, because it will drop. Understood?
Something you early, like, get into in another class, but if they're acidotic, isn't the potassium high?
Yeah.
Okay, so then, you're saying, what you're saying, they're usually, something hypo.
So the hypokalemia, so again, there's an outside thing which is causing which is causing the potassium to be high at this moment, and that's the acidosis. We're about to correct that acidosis. How much potassium do they really have in their body once we get rid of the acidosis? Not enough to keep them going. Okay, not enough to keep them going. We gotta get that fixed. Good, we got the potassium up, now we want to give them some insulin. It's 0.1 unit per kilogram per hour, right? If it's DKA, 0.05 unit per kilogram per hour. If it's IPK. So basically treat the ABCs, get that hydration going. First do potassium, then decide how much insulin you want to give. Some people say you give bicarb because they're acidotic. Really, that's only helpful if it's severe hyperkalemia. You measure it at 6.8, and they're super acidotic at 6.8 for the big number rating at pH, right? Then you give bicarb. They need finger stick glucose QH hour, Q hour per hour, and BNP Q2 hours. And the mental status must be measured every hour. Mental status must be measured every hour and documented because, as you're about to see, one of the biggest complications is going to be cerebral edema. Don't miss it. Two main complications that can come about are they become supremely hypokalemic or they get cerebral. So what is cerebral edema? So listen, the brain is really smart. The brain is really smart. The brain sees there's something going on here hydration-wise. And it creates cells in the brain cells to stop too much fluid from leaving the brain. So it can hold on to water much better. Now, once you start introducing a ton of fluids to this patient, those fluids are introduced quicker than the brain is able to get rid of those extra cells, which are meant to keep fluid in, so it can start to swell up a lot. That's cerebral edema. So when you're giving someone fluid because of extreme dehydration, look for Q1 hour. You probably want to check for headaches, any changes in how easily they're aroused, seizures, pupillary changes, blood pressure changes, bradycardia, incontinence. If that's happening, if you suspect cerebral edema, give mannitol, or begin having respiratory failure before you use mannitol and/or hypertension. The goal of PKA is essentially of giving insulin is essentially to resolve acidosis, get the insulin down until the glucose is good, and two of the following: anion gap is corrected, the bicarb is corrected, the pH is corrected. Just pick two of those and glucose down, and then you can stop the insulin. If the glucose is down below 250, but you still have acidosis, well, blood sugar is great. You're going to add some 5%, some D5 to IV fluids. Just think about it. Right now, we have to keep giving the insulin. The blood sugar is now 185. We want to get something to balance out the insulin at the stage 2, so you start adding D5 there. And then in special populations, sometimes DKA can exist, such as alcoholics, people who are pregnant, people who are taking SGLT inhibitors. They may have DKA even. I'm not going to get into this chart right now. It's just a basic flow chart. Everyone okay with DKA? Hypothyroidism. Thyroid is the type, hyperthyroidism are going to be people who are sped up, fevers, tachycardia. Yeah. Yes, except you don't have to worry about you won't have to worry about the potassium as much because you don't have that acidosis. Good question. Hydration is going to be the main thing. Hypothyroidism are going to be these people with puffiness, hair loss, fatigue, cold intolerance, maybe cold breath, dry skin. And they may get something called mixed edema. So we've heard of pitting edema. We've talked about pitting edema when we talked about PHF or other possible fluid buildup, third space. This is non-pitting. This is non-pitting edema. This who has called mixed edema in a patient with hypothyroidism. Sometimes people's thyroid levels can get so low that they go into crisis. May even cause AMS, may cause hypothermia. Hypothermia is so common in these mixed edemic patients that if they have a normal temperature, they may have an infection. Okay. So this is the one time when someone with a 98.6 is concerned. So how do I know it's not real hypothermia? Maybe they're just cold, maybe it's exposure. So they're not going to be shivering. They're not going to have, they're not going to look like they're cold. They're going to have a low body. So we have to find out what's causing this. And we can get some labs, TSH, T4, T3, cortisol. And the problem is they don't have enough thyroid hormone. What do? How do you cure it? Give them thyroid hormone. Give them T3, give them T4, give them hydrocortisone. Maybe antibiotics if you're afraid it's an infection that causes crisis. If you're worried about there being MI or hard glycogen KG, right? Is there any hyponatremia? We can fix hyponatremia. If there's volume depletion, fix volume depletion. If there's hypoglycemia, give them some. If they're cold, what can you do for them? Warm blankets, right? You can treat the symptoms, but really what's causing it in these patients is going to be the low T3, T4, so you can give them T3, T4. On the other end of the spectrum, people with hyperthyroidism, you don't have low TSH, but their brain's saying, whoa, too much thyroid hormone. But their thyroid is still putting out a bunch of thyroid. So sometimes there's something called subclinical hyperthyroidism, where there's a normal amount of thyroid hormone, but the body's like, it feels like it's a little much. So the TSH will be low, but the normal T4 will be, they're not going to have these symptoms. But what happens when they have too much thyroid hormone is something called thyrotoxicosis. And sometimes it can become life-threatening enough to be a thyroid storm. Thyroid storm. Where does thyroid storm look? Well, there's four things we're going to see. Four symptoms are going to see. They're going to have cardiovascular, you're going to see pulmonary edema, tachycardia, pulmonary AFib, possibly bivasal cavitation. They're going to be super hot. They're going to have fever. They're going to be screaming, agitated, maybe even psychotic. Or on the other end of the spectrum, they might be in a coma or lethargic. And you're going to see nausea, vomiting, diarrhea, jaundice. Your body's in overdrive. You need to find out, like, is this coming from an infection? Is it something else? Are they in cocaine withdrawal? Do they get into Farmer John's insecticides? Could it be the pheochromocytoma that some of you have heard about that doesn't only medical students have ever, maybe one right? When I say med students have actually found it, usually like the doc doesn't see it like that. All right, so it could be some systemic insult, trauma, infection, could be an MI. Could be they stopped taking their anti-thyroid medication. Right, so the thyroid went into overdrive. Could be they've been taking too much iodine. You do not need to know this chart. You do not need to know this chart. But this can be helpful in seeing what is helpful in diagnosing what sort of criteria. With 10 slides left, we'll take it. Okay. So pay attention to these steps. Pay attention to these steps. Step one, always find out, first of all, if this patient is pregnant or breastfeeding. Get an HCP. If they're pregnant or breastfeeding, stop. Get it. Done. You're not going to touch this as an ER diagnostic specialist. Okay? That's the easy. HCP comes back negative. Next, hey, get them feeling better. This is really step two. Before anything else, get them feeling better. Make sure they have oxygen. Get them on a heart monitor. Get that fever down with some Tylenol or a Motrin or ice packs, right? Don't give them aspirin. But at least with Tylenol or Motrin, ice packs, get that fever down, get the heart on a monitor, make sure they're able to get them oxygen. And we're good so far, right? All we've done is take care of this person, right? Now let's get them healthy. So now, remember their body's in overdrive, so they're hypertensive. Get it down. Calm them down. Beta blockers, calcium channel blockers. Let's slow that whole system. Okay, adrenergic effects. Let's get that. Okay. We've now got the person relatively back to a normal state. Fever down, got them in oxygen, slow their blood pressure down. Now we can start working on making sure there's not more thyroid hormone being created. Okay, the best thing to give them that is PTU. PTU stops the T4 becoming T3, essentially just know PT. Methimazole, that's only for second or third trimester, so it's always going to. That's just basically going to stop the thyroid hormone from being continued to be synthesized. Good. Got them healthy again. We got the thyroid hormone no longer being created. Yes, that's just a fun fact. You might say, hey, doc, I have a pregnant woman with thyroid hormone down here, you'll be going and starting. Right, you may say that, and they'll say, no, don't worry about it, right? So that's just so you can sound super. You're right, you're marking that thing. Okay, good. We have them feeling better. We got them under control. We stopped the body from making more thyroid hormone. Everybody stop for an hour. Do not do anything for the next hour. Let everything sort of simmer. Okay? Why? Because if I would give iodine, going to be the next treatment, it's going to be immediately taken up by the thyroid and everything's going to start over. We need the PTU to start doing this job of not creating more thyroid. Then I can give iodine. What iodine is going to do is going to stop the thyroid from releasing new hormones. It's no longer creating, it's no longer going to release it. If the reason they have a thyroid storm is because they're taking amiodarone, or they're sensitive to iodine, or they took too much iodine, we don't use iodine. Yeah.
Because they're instead of you'll be also treating whatever you figure out underlying causes that's causing the thyroid storm while we're doing this, or is this just like thyroid storm?
No, you're correct. After you stop the thyroid storm.
Okay, so
These are the 8 steps to stop the thyroid.
stop the thyroid storm,
But yes, you will need to treat the underlying cause.
Okay.
Yeah, but let's get them healthy, get them relatively healthy first. Yeah. Yeah, but if it was being caused by medications like amiodarone, or they took too much iodine, or something like that, then you don't use iodine to stop it. Makes sense. Then you want to give them some steroids. And then finally, we want to stop more hormones from being released, which is cholesterol. Those are 8 steps. The first 5 are relatively intuitive. The next 3 are, they're gonna be memorization. Yeah, sorry. But those first 5 hopefully will be a little more intuitive, right? Find out if they're pregnant. Get them feeling better. Get them feeling better with drugs, beta blockers, calcium channel blockers. Stop the body from creating more with PTU, and then let it marinate for the next 3 hours. Okay? Because you just haven't had into it. But hopefully this will help you. Okay? And then, like Ryan was saying, treat whatever's causing it and get them advice. All the people we're talking about today are probably maybe not hypoglycemic. But everyone is. And definitive therapies, you might need to do an ablation prior to the surgery. Okay. Everyone okay? We're in the home stretch of endo. Yeah.
No, all that. Given that communication, they would tell you they go through that.
Hopefully you'll have them stable at that stage. Yeah. But you're right. If we don't know, then you have to assume that it's not. Unless you give them iodine and start getting worse. Yeah, if they're non-responsive, then you just have to. But that's why it's good to get a good history. All right. Okay, adrenal insufficiency. So, I've got to explain this real quickly. Adrenal insufficiency. So, adrenal glands basically give you aldosterone, the ability to deal with stress, right? The most non-acute version of it, if it's insufficiency, is called Addison's disease, which famous president? Mayor JFK. Yeah. Yeah, JFK. You will get tired very easily. And interestingly enough, one of the side effects of Addison's is excess of melatonin. So he actually had really tanned, bronze skin, and everyone was like, "Oh my gosh, this guy's so healthy, he's out in the sun all the time," right? But it was because he was like very sick. Tune in next week for more presidents. Yeah, Lincoln had Martins. Garfield was shot, and he died. Well, yes, that's one thing, just a problem. But what really killed him, was they had this brand new technology to try to find the bullet. They had metal detectors. So they were trying to find the metal, they were using metal detectors to find the bullet in his body so they could remove it. And they kept fighting and trying to dig for it, and they couldn't find it anywhere. And then they realized, oh gosh, but that is metal springs. And I like to think at that point, they looked at each other and said, "We're never speaking of this." Right? So you're gonna pretend none of this will ever happen, right? Yeah, that's an embarrassing moment in history. Guys, we just got the president, right? All right. So what happens with this? Let's say Addison's gets so bad, they're in adrenal crisis. Okay, that's a life-threatening presentation. There might be an acute stressor. It might be a sudden, like a GI illness, surgery, strenuous activity. They stop taking steroids all of a sudden when they've been taking them for years, alcohol withdrawal, or it could be some sort of trauma. Basically, the amount of cortisol, the body's supply of cortisol and aldosterone can't meet the demand that the body needs. So they might look very sick. They may look like they have meningitis or sepsis. They may be hypoglycemic, glycemic. They may have neuropsychiatric complaints, chest pain, abdominal pain, gonadal failure, hypothyroidism. Those all might be causes. Of course, you have to rule out meningitis or sepsis. It might be that they are hypertensive and look like a distributary shock, vasodilatory shock. But you keep giving them vasopressors, you keep giving them fluid resuscitation, they're not getting better because their body still doesn't have its needs for steroids. Right? So what you can do is get their sugar, get CBC, measure their electrolytes, liver tests, EKG. And then based on what you think is going on, continue chasing that. And then you're just gonna start treating. Just start treating them, don't wait for the results. Ideally, the diagnosis with figuring out if this is what's going on, is the ACTH levels or cortisol levels, but that's probably not happening. That's it. But, you know, if you happen to get it back and they're sitting there long enough, then it might help you. So how do you treat them? Again, stepwise, and this is our last slide. 14, great. First of all, give them fluids. If they're hypoglycemic, give them some D5. That makes sense for hypoglycemia. And since they have steroid withdrawal, they don't have enough steroids in their body, what do? Give them steroids, right? Good. Supportive care, obviously the ABCs from the beginning, then also get their electrolytes going, make sure you can try to correct their AMS, if there's an electrolyte cause. Do they need vasopressors? Because they're so hypoglycemic, they might. Then you figure out the cause, and then finally, once you get them stable, you figure out, okay, the problem was he didn't have enough steroids. We got them a little fix. How can we give them more steroids? How much do they need? Then you ship them off to the questions on the endo. Basically, we talked about a few things. We talked about hypoglycemia and hypoglycemia and hyperglycemia. So hypoglycemia is easy, give them sugar. Hyperglycemia, DKA, a little tricky, but mainly give them fluids. Correct the sugar, but first make sure the electrolytes. Then we talked about thyroid issues, mixed edema versus thyroid hormone, thyroid crisis, thyroid storm. And essentially that is treat the symptoms if they're not pregnant, if it's a thyroid storm, and then try to get the body to behave and become slow. Essentially what it is. In a nutshell, hypothyroidism given thyroid. And then adrenal insufficiency. So really, this is just getting a picture of what do these people look like, what's causing it, and giving them back. Okay. Marinated and think about it. So everyone's getting. Hopefully, you'll have clean numbers before you. As you should. Still struggling with it, reach out. In the meantime, take a 7-minute break.